Hi, I'm Ron Berkman, and today I will be reviewing the maneuvers utilized to manage a shoulder dystocia complication. By reviewing the video, certainly participants should be able to describe the performance of release maneuvers used to manage shoulder dystocia, and hopefully be able to manage these complications when they do occur. Now, when you look at algorithms used to manage shoulder dystocia, keep in mind that there is no one, shall we say, standard algorithm. There are multiple algorithms, and basically one utilizes one that has worked for them and that one feels covers the sorts of maneuvers that they're comfortable doing that resolve the situation. Certainly the first step is to recognize that you've got a shoulder dystocia. So you have a patient with a vertex presentation who's bearing down in the second stage of labor, and you're exerting axial traction, and axial traction being traction in line with the vertebrae of the fetus, and at that point you recognize that the anterior shoulder would not deliver. At that point you've made the diagnosis of shoulder dystocia. It's important to stop your traction and have the patient stop bearing down, because further bearing down and traction will only impact the shoulder further behind the symphysis. It's important that you communicate with the staff and patient as well as their family, letting them know that you're now basically taking charge. They should give no instructions at this point, and the patient should only listen to you, and the staff really has to listen to what you need and desire them to do. Certainly it's important at this point to call for help and begin timekeeping. The first maneuver usually is the Mick-Roberts maneuver. It's simple to do. You can even utilize family members to assist in doing the maneuver. And frequently, after doing the maneuver, further bearing down and traction will resolve the shoulder dystocia in a significant proportion of cases. So it's certainly the best maneuver to do initially. I list episiotomy here only to point out that occasionally you will need an episiotomy in order to allow one to insert their hand into the posterior part, just in the perineum, in order to do a rotational maneuver or to deliver the posterior shoulder. But that does not have to be routinely done after Mick-Roberts maneuver. And keep in mind, it really is not used to resolve the shoulder dystocia, because the shoulder dystocia is related to bony parts causing the fetus not to deliver. Next method usually utilized is suprapubic pressure. Again, you have to instruct your assistant or a nurse or whoever how to do this. And this oftentimes can be combined with a Rubens maneuver. The next maneuver listed is the posterior arm. There is data, at least from one large study, that suggests that when suprapubic pressure and Mick-Roberts fail, posterior arm delivery is more likely to be successful than some of the other maneuvers. However, this is not sort of cast in stone. Next maneuvers listed here are the wood screw maneuver or Rubens maneuver. It's important to keep in mind that when you have a significantly obese patient with a large pannus and so forth, oftentimes a suprapubic pressure may be inadequate, and the Rubens maneuver essentially accomplishes the same thing, and certainly is probably a better maneuver to utilize than spending a lot of time trying to do suprapubic pressure. Keep in mind also that you can repeat these steps if the delivery is not accomplished. There is more time than you think to resolve the situation. I list next the Gaskman maneuver as opposed to putting it further up on the list, only because it requires you to put the patient into all fours. She can't have obviously a dense epidural. And if it doesn't work, then you have to eventually get her back on her back. And this, again, uses up time and does require 2 or 3 staff members to get this in order. I list also a relatively newly described maneuver called the posterior axial sling traction maneuver. This certainly could be up on the list as opposed to where it's situated here. And finally, if all else fails, you can certainly go to the Zavanelli maneuver followed by a cesarean delivery. Mick-Roberts maneuver, this is probably the first maneuver everyone uses. It's simple, it's logical, and it's highly effective. Basically, as you will see in the short animation that will come next, is you'll see that the symphysis and sacrum basically rotate cephalad, that is, towards the head, and you see that the spine flattens to basically eliminate lordosis. By so doing, this again results in some additional room to deliver the fetus. And there you can see the sacrum and the symphysis rotated towards the head, and you saw that the lumbar spine flattened out. And again, you can see this leads to release of the baby. The next maneuver is suprapubic pressure. Essentially, you're applying pressure above the pubic bone in a downward and to side direction. Ideally, you want to do this pressing on the scapular side, because by so doing, oftentimes you also will have the shoulders sort of go from a sort of military position or presentation to more a hunched presentation. However, if in fact the baby does not move when you're pressing on the scapular side, there's certainly nothing wrong with going to the other side, particularly if it does result in moving the shoulders into an oblique diameter. Once you get into the oblique diameter, oftentimes by the movement, you'll get the anterior shoulder below the suprapubic bone, or you'll be in a diameter that gives you additional room to deliver the fetus. And here you see the hand going to be applied suprapubically above the shoulder, and again, it causes the shoulder to sort of hunch up a little bit and also go into this oblique diameter, approximately 30 degrees to one side. Rubin's maneuver is very similar to applying the suprapubic pressure maneuver, except that you're using the fingers of one hand, or the entire hand if you can get it in there, to do the same thing. As I pointed out earlier, I think it's ideal, particularly if you have obese patients where the suprapubic pressure maneuver may not be adequate. And here you see the hand in the vagina on the anterior shoulder, and again rotating the baby again 30 to 45 degrees to allow delivery. Posterior arm delivery, this again is something that requires at least some knowledge of how you're going to do it. Essentially, one inserts your hand and makes sure that it's in a cupped sort of position so that it will fit into the posterior perineal area. You then try to grasp the wrist of the posterior arm. If you can't, pressure on the antecubital fossa will basically flex the arm so that will facilitate grasping the wrist. You then sweep the posterior arm across the chest and out. Fracture of a clavicle or humerus may occur, but most of these fractures usually heal without long-term sequelae. So here we see the hand going in. They've grasped, or the person has grasped the wrist, sort of tracks it down, sweeping the arm across the chest, and then pulling the wrist past the head. And usually, again, this results in the shoulder being delivered. The Woods maneuver is basically rotating the fetus to and fro through 180 degrees. By doing this in a sort of screw type situation, this results in delivery of the anterior shoulder. And here you see the hands positioned as shown. And the first rotation will again go 180 degrees, bringing the posterior shoulder anterior, and hopefully somewhat more distal from the symphysis pubis as the prior anterior shoulder was. If it doesn't do this enough where you think that with traction you're going to be able to deliver the fetus, you again can rotate back again and go back and forth until the baby is delivered. The Gaskin maneuver, as I pointed out, may be difficult to accomplish with dense epidural anesthesia. Basically, it displaces the fetus out of its impacted position, allowing delivery via axial traction or use of other maneuvers. And here, and this is a little slow in sort of kicking into gear, you can see, again, everything's reversed. The pubic bone is posterior and the back is anterior. But you can see, as you get the patient on up as shown, that the fetus sort of relaxes and drops in. The posterior axial traction maneuver, or PASS procedure, has been written up in the last few years. To do it, you would use a number 12 or 14 GI tubing, which has minimal stretch, and that type of tubing is used for certain numbers of neonates. Or you can use your 2 index fingers if, again, there's enough room to get them into the position that you need. It basically produces a shrug of the posterior shoulder, which allows delivery of that shoulder. And here we see it on a model. Here you're taking the tubing, you're doubling it up, and then this allows you, hopefully, to slide it in through the axilla and be able to hook your finger in that loop. And then with traction, as shown here, you basically shrug the shoulder, and then you can pull it out. In addition, in some of the write-ups, they also point out that you can rotate the fetus at this point, sort of a combination PASS procedure with a Wood's corkscrew maneuver. Zavanelli maneuver is something that one uses when other maneuvers have failed. Certainly the use of some uterine relaxation may help. Important to recognize, it requires doing the cardinal movements in reverse. It also is most effective when the posterior shoulder is not significantly impacted into the sacral hollow. So here you can administer a tocolytic. Here you see rotating the head back from what had rotate for externally, and then rotating it once more, and then flexing the head and pushing the baby up to get it delivered. So in summary, I've gone through with you the various maneuvers utilized to resolve a shoulder dystocia. Ultimately, you need to develop and use an algorithm that you are comfortable with to manage shoulder dystocia. Remember, when it occurs, you need to take charge, get help, and importantly, don't panic. You do have more time than you think to resolve the situation. If you obviously, if you're going to document, it's important not to document while managing the shoulder dystocia. You should wait till it's resolved. Again, coordinate exactly what happened with the nursing staff, and be sure that the appropriate steps are listed, and you avoid comments that could be damaging should litigation occur if the baby happens to have a palsy. Hopefully you found this useful, and hopefully you will be able to handle shoulder dystocia more effectively moving forward.